Can you hear us? Can you open Zoom? Miriam, if you can hear us, your microphone is off, and also the camera. Yes, I can. Can you hear me? Not yet. They are working on it.
So just for my question. Oh, I can't hear you very well.
Okay, can you hear me now? Miriam, can you hear me? The microphone is...
Can't hear you actually.
Because the microphone is off. Can you hear me now, Miriam?
Yeah, I can hear you now.
Yes, during the question and answers, you need to stay online all the time. Camera
The
on.
whole time, okay.
Okay, thank you. Good luck with the meeting.
Okay, thanks. Bye.
Discúlpeme.
In Colombia, for example, our teams have worked with national and local health officials during the pandemic to manage and reduce risks at its borders. To achieve better health for migrants and refugees, we must invest in more research to build evidence that will help governments bridge the policy gaps and make better decisions. That's where people like you come in, to advocate for better health and to work with us as we protect the health and safety of migrants and refugees. No one group or agency or partner or organization can do this alone. We are all in it together. So thank you for what you're doing to help save lives and to ensure that migrants and refugees worldwide have access to the health care they need and deserve. Our common goal is a healthy society, no matter where people are from or where they live. Thank you.
Hola, hola. ¿Me escuchan? Canal de español, canal de español.
Hello, can you hear me? This is the Spanish channel, 1, 2, 3.
Guay.
One, two. Esta es la traducción, 1, 2, 3. ¿Puedo escuchar? 1, 2, 3. Este es el canal español. Un momento. 1, 2, 3. This is the English school, the 5th global school on refugees and migrants' health. 1, 2, 3. I'm going to speak a little bit longer so that we can see the translation for today. We're going to begin today with the topic of research for the health of migrants and how much we have to work in order to improve the productions in health based on evidence. And we hope to have more than 100 people on the floor and more than 3,000 people online at a worldwide level. We are having currently and the surveys have been very positive in respect to the results and what this global school is leaving behind it. Can you hear me okay? This is the Spanish channel. I'm doing a test.
I'm going to speak in English now. This is the 5th Global School on Refugees and Migrant Health. We are in Bogota. We are hoping to have a great day today. We are expecting to have more than 3,000 people connected online and listening what is going on this topic. Then we have universities invited to have a good session and afternoon. Can you hear me well? This is a test. This is only a test. Can you hear me well? How is YouTube? How is YouTube? Estamos hablando, I'm sorry, I'm speaking in English. This is an English channel. This is an English channel to test. We are in the 5th global school. We are in the global school. We are testing the system. We are testing the system to see if YouTube channel in English and Spanish is working well. ¿Podemos probar dejándolo en el mismo canal primero? Voy a estar en el canal español permanentemente. Ok, vamos a probar en un solo canal sin cambiar. Lo que vamos a hacer es que primero voy a hablar en español y después voy a hablar en inglés. Voy a cambiar y usted cambia. Ahora estoy hablando en español para probar los canales de YouTube. Vamos haciendo la prueba. En YouTube yo estoy hablando en español, es el canal de español de la Escuela Global de Migración. Estamos haciendo la prueba en español y estoy probando el alcance del micrófono también para que no se corte. Estoy haciendo la prueba en español para ver si se escuchan ambos canales. Por favor, confirmen que ambos canales se está escuchando mi voz en español y la traducción en inglés. ¿Pueden escuchar mi voz en español y en inglés? No.
Ok, voy a pasar al canal español. Perdón, al canal inglés voy a pasarme. ¿Paro? Cada idioma. Ok, podemos entonces hacer la prueba uno. Yo, sin necesidad de que me hable, yo voy a hablar en un idioma. ¿Otro le parece bien? Okay. As I was going up the stairs, I met a man who wasn't there. He wasn't there again today. I really wish he'd stay away. The reason for the pelican is difficult to see. His beak is clearly larger than there's a need to be. It's not to bail a boat with he doesn't own a boat. Not a scoop for eating soup. It's not an extra shoe. It isn't quite for anything, and yet you realize it's quite a splendid beak, quite a splendid size. Ese fue el canal inglés. Voy a pasar ahora al canal español. ¿Está bien? En la nada estaba yo porque salí de la nada a execrar la hora menguada en que mi vida empezó. Y una vez que se cumplió ese prodigio funesto, porque el mismo que le ha impuesto de él no me viene a liberar, he de tener que cargar un bien contra el cual protesto. Alma, si vienes del cielo, si eres imagen cumplida del soberano modelo, digo en el suelo la fe de tu original, como en tu lengua inmortal no explicas al hombre rudo ese fatídico nudo entre un dios y un animal.
Sí, no sé, se salen los dos canales. Ok, vamos a hablar los dos juntos. Tenemos que hablar los dos juntos para hacer las pruebas. We do the test together. No only one. Okay. Primero hablo español y inglés. I'm going to speak in Spanish now for testing. I'm going to speak in... perdón, voy a hablar en español. Voy a hablar
To speak
en
in
español.
English now, I'm going to speak in Spanish now. This is the Spanish channel. This is the 5th Global School. We're just about to begin. This is the Global School, and you're just about to begin. This is the Spanish channel. This is the Spanish channel. Can you hear me okay? This is the Spanish channel. Can you hear me? Can you hear me? Please, testing the YouTube channels, the Spanish channel, please. Can you please verify whether you can hear me? Can you please verify whether you hear me? Sorry, this is the English channel, not the Spanish channel, the English channel. Can you hear me in the English channel?
I'm going to speak in English now. I'm going to speak in English now. Testing, testing. This is a floor microphone in English. I'm going to speak in English now. I need the translation in Spanish. This is a testing. This is an English channel. Please check the YouTube. It's the English channel is working well. You hear me well? Do you hear me well? It is a testing. It is a testing. Perfect. Perfect. Thank you.
One more thing, I will connect from Zoom, speak in Spanish, and let's see how we will hear it on YouTube, on English. And I will connect to YouTube, speak in English, and let's see how it goes on YouTube.
Como si alguien se conectara. Sí, si alguien se conectara con la traducción. Okay.
Good morning, good morning, good morning. Good morning, good morning. Okay, so this is for testing if the Zoom interpretation works well on YouTube channel. Can you hear me loud and clear in Spanish channel and English channel? On YouTube, there is delay. You cannot hear me now. Can you hear us?
Yes, I can hear.
Okay. If you can say just few words, I think we should be okay.
I will also try to look at the, yes, I will blur the background. I
Yes.
guess then it's a bit better. Let me do that.
We will lose the trophy in the background, but it's fine.
Okay. Good. So how is the sound?
It's perfect. Can you hear us clearly?
Yes, I can hear you clearly.
Okay. If you should always be in the English channel, mute the background voice, and then everything should be audible to you. There may be small hiccups, and if there's any unclarity about the question that you receive, you can ask to the presenter again, and she should be able to guide you.
Okay, wonderful.
Okay, thank you,
Thank
Christina.
you.
Bye-bye.
Thank you. Bye.
Good morning, good morning. This is very much to quickly test the Spanish interpretation. Good morning, good morning. This is very quickly to have a Spanish channel interpretation test.
Hola, hola, sí.
Es este. Sonido, sonido. Este es el. Es. Sonido, sonido. Uno, dos, sí. Ey. Sonido, sonido. Uno, dos. Es.
Hola, hola, hola. Hola, hola, hola.
Buenos días, estamos por comenzar. Muchas gracias por estar acá nuevamente.
Good day, we're about to begin. Thank you very much for being here again. It should be a very interesting day. It's our fourth day. In a few days, we're going to begin our transmission for our audience that is going to connect online. So I'm going to switch over to English, but you already know what are the announcements. I imagine you've already learned them by heart. Participating with questions during the panel. It's been very interesting, the amount of questions that we've received, and also the comments that I've heard in the social networks. Let's see who's used the social networks. 1, 2, 3, 4, 5. 5 is a very short number. Let's see if today we're able to make it. We're going to use hashtag in English's hashtag migration health. So you completed the survey yesterday in the afternoon? Was it easy? Good, perfect. We've received a great amount of comments. People are very dutifully filling it out. They are interested in the participation certificate that we'll always obviously receive if you filled out the survey every day. Candelaria has just told me that we're just about to begin. You can see here in the screen, and we can begin.
Hello, hello, everybody. Thank you for being here again. Today is the fourth day of our school. Remember, this is the fifth edition of the World Health Organization Global School on Migrant and Refugee Health. And I want to tell you that you have been crucial for the success of this event, because with your questions, not only in number, but also the quality of them, with your engagement, with your participation, you have been very engaged with this event, and you have made our job worth it. So thank you for that. Today, we are going to focus on a topic which is how to close the gap between the research and the formulation of public policy. And I think this is like the most related topic with the main subject of the event. But I don't know if I'm wrong or right, so to answer that and to correct me, I'm going to invite our host and one co-facilitator, Dr. Santino Severoni. You know him very well. Welcome, Dr. Severoni. Good morning again. How are you? Pretty well. We are missing the other mic? No, it is here, yeah. Let me see if this is okay to connect these dots. The main subject of the event is how to go from evidence to action to guarantee the access to health for migrants and refugees. And the topic of today is how to close the gap between research and the formulation of public policy. So by research, you get the possibility to get the evidence. By public policy, you get the possibility to go to action. So it is right to connect those dots?
Absolutely, and good morning again to everybody. Indeed, this is a very important component of our work, not only because health and migration for the health sector in certain extent have been sounding as a new area of engagement. So we identify a clear need for recasting the existing public health evidence factoring in health and migration, but also we identify a number of gaps. So the necessity to have a strong evidence to support our policy speculations and public health action is essential. Otherwise, we are just basing our action on fairy tales, on narratives.
Exactly. Well, let's switch places because I don't know why today we are in different places. And it is happening to you that when you settle in a place, you want to stay in that place? It happens to me.
I'm pretty nomadic, so I'm flexible.
Okay, thank you very much. Well, I know I'm sounding repetitive, but I have to remember the announcements of every day. For us, it's very important your participation, so keep sending your questions for Dr. Cabieses to moderate the roundtable discussion, and also keep using your social media platforms to let the world know what is happening here. Just make sure to use the hashtag, which is, as I said, migration health in English and salud migración in Spanish. And remember to fill the form at the end of the event. This is not an evaluation. This is not an evaluation for you. It's an evaluation for us, and this is our way to get your feedback. We have received a lot of comments from you. Thank you for that one. And today we are going to share again the form for you to fill it out, because this is a requirement for you to get your certificate of participation. And choose the language of your preference using the word icon on the platform, or the translation equipments if you are here, as I see you already do. Well, we're going to go. So what about having the first remarks of the day? Those are from Ms. Amy Pope. She is the General Director of the International Organization for Migration. So let's see her message.
It's an honor to speak with you at this 5th Global School on Refugee and Migrant Health. And I want to thank you for the work that you're doing to protect the health of people on the move. At IOM, we are proud to be a key partner in the WHO Global Action Plan on promoting the health of refugees and migrants. Around the world, migrants play an important role in the economies of countries of origin and destination. They're often on the front lines in healthcare, and we all remember during the COVID-19 pandemic how many hospitals, clinics, and other healthcare facilities were staffed by migrants. Yet, we also know that migrants and refugees often face barriers to essential health services, and they're too often left out of universal health coverage plans. So one of our key roles at IOM is to help governments come up with policies that enable migrants to get the health care they need. Last year, our health assessment programs helped more than 1 million refugees and migrants across more than 50 countries. These programs support evidence-based, migrant-centric health protocols, such as integrating TB diagnostics and treatment. We also harness the power of our data to improve health and healthcare systems worldwide. IOM's displacement tracking matrix and other mapping tools help governments enhance their preparedness and their planning for disease outbreaks. In Colombia, for example, our teams have worked with national and local health officials during the pandemic to manage and reduce risks at its borders. To achieve better health for migrants and refugees, we must invest in more research to build evidence that will help governments bridge the policy gaps and make better decisions. That's where people like you come in, to advocate for better health and to work with us as we protect the health and safety of migrants and refugees. No one group or agency or partner or organization can do this alone. We are all in it together. So thank you for what you're doing to help save lives and to ensure that migrants and refugees worldwide have access to the health care they need and deserve. Our common goal is a healthy society, no matter where people are from or where they live. Thank you.
The director of International Organization for Migration remarks something that is very important, which is the coordination between different levels of the same organization or different organizations, because no one can this by itself.
Well, also because the topic of migration management interesting several sectors. So coordination is essential in order to join forces, in order to have a coherence in the action, and the partnership certainly increase the critical mass of capacity to address needs.
Well, thank you, Dr. Santino. Now we are ready to have the example from a country. In this case, it's a very inspiring country, which is Estonia. They have received many migrants from Ukraine. So let's see how this country has done in terms of researching to do the best way possible with these migrants.
Мене звати Ганна, и я беженка из Украины. Мы выехали из Украины в первый день войны, начали выезжать с маленьким ребенком. Моему ребеночку тогда было на момент начала войны 8 месяцев. Дорога заняла 1,5 недели до Эстонии. Это была очень тяжелая, нелегкая дорога.
Estonia, a Baltic country in Northern Europe, a pioneer in technology and e-services, is home to about 1.3 million people. It sits along the eastern shores of the Baltic Sea, bordered by Russia to the east, Latvia to the south, and just across the water, Finland. For years, the number of refugees and asylum seekers arriving in Estonia was quite low, with fewer than 100 asylum applications received annually until 2015. In 2022, migration surged significantly, with over 42,400 refugees and asylum seekers arriving, including more than 38,000 Ukrainian nationals under temporary protection. At the time when the health system review was completed in May 2024, Estonia was hosting more than 38,000 Ukrainian refugees. In fact, the year before, Ukrainian nationals made up over half of all migrants entering the country, reshaping Estonia's migration landscape. In Estonia, the Ministry of Social Affairs oversees health policies, including those for refugees and migrants, ensuring healthcare for everyone residing in the country. Estonia's health system is centralized, with local municipalities delivering some social and health services, while the financing, organization, and coordination of health services are managed at the national level through the Ministry of Social Affairs. Family doctors serve as the first point of contact with the health system, referring patients to specialists when needed. To access healthcare and health insurance, refugees and individuals under temporary protection must first obtain a residence permit and an Estonian ID number. However, emergency care is free for everyone in Estonia.
В Эстонии хорошо организована электронная система записи к врачам. Не нужно никаких справок, все есть в системе. Также качество медицинской помощи на хорошем уровне.
Understanding the health needs of refugees and migrants is crucial for creating inclusive health policies, for ensuring access to health services that are needed by refugees and migrants. This will also enable us to move towards universal health coverage, which is our main goal in WHO. There was an influx of refugees and migrants in Estonia in 2022, and the need came from the pressure to the health system, where we wanted to look what are the obstacles, is there something different among refugees and migrants when they want to access the health services, and what are the possible solutions. And also we wanted to map what are the different best practices that are used in Estonia that could be also replicated in other health systems. We conducted this review in partnership with Ministry of Social Affairs of Estonia, but also with key partners like International Organization of Migration and United Nations High Commissioner for Refugees and other national stakeholders in Estonia. One of the most critical areas of improvement that came out with the review is access to information, both for refugees who are seeking services, but also for officials who are trying to meet the needs of refugees.
Самым трудным было понять, как записаться на прием к врачам, найти семейного врача, попасть к узкому специалисту и, конечно, ожидание по пару месяцев приема. Помогло изучение веб-сайтов и советы от других мам в местных группах.
For family doctors, the main problem is different healthcare systems. Refugees are not familiar to our system. You cannot enter secondary care without family medicine. In Estonia, family doctors do a lot. We can help with 80% of health problems. It can be difficult for refugees to adjust to this. Also, family doctors are not aware of services available for refugees. Even a simple one-pager about it would help us. Language is a second barrier. Estonian language is difficult. This makes it more harder for refugees to find a family doctor.
Найти информацию на русском языке было несложно, но на украинском языке было очень мало информации. Иногда приходилось на приеме использовать переводчики, чтобы понять важные детали. Было бы полезно предоставить больше переводчиков в медицинских учреждениях и увеличить, конечно, количество врачей, к которым могут обращаться беженцы.
The review confirmed and validated the informal and anecdotal reports about refugee and migrant experiences of Estonia's health system. Many of the issues brought out in the context of refugees are problems in the healthcare system in general. Long waiting times, shortages of some healthcare specialists, lack of specialists in rural areas. This makes sense as our goal is to integrate migrants and refugees into Estonia's health system, not create a parallel one. A key challenge highlighted in the review is communication and information, making sure that people know what service should they use in what situation. We need to make sure that we take into account the people's cultural and social background, as well as the situation at hand when communicating with them.
One key area of improvement is the need for health mediator counseling sessions to help refugees navigate the health system. IOM is planning regular counseling sessions in Tallinn Migration Center starting November, and there is significant interest and strong demand for this service. The role of a health mediator is to assist refugees and migrants in accessing healthcare services in Estonia. If necessary, I help with registering in the family doctors list, booking specialist appointments, and if needed, accompany individuals to their medical visits. Additionally, I explain the rights, obligations, and common practices of patients in Estonia and demonstrate the functionalities of the online health portal. We need to empower migrants by improving their health literacy. By providing workshops and educational materials, they can navigate the healthcare system more independently, ensuring that mediator resources are used more efficiently.
It would be great if all our health system specialists were more fluent in cultural competence, meaning all people working within healthcare would receive consistent trainings on how to interact with people from very different cultural and religious backgrounds. Also, it would be great if specialists knew about the mental impact forced migration can have on someone.
In 2023, Ministry of Social Affairs implemented a special support initiative to provide mental health services to Ukrainian refugees, benefiting around 8,000 individuals. However, there is still a pressing need for more permanent solutions. Estonia, like many countries, faces a growing shortage of mental health professionals. To address this, we must invest in training new specialists. We also need to ensure that quality mental health services are accessible in every corner of the country. Moreover, refugees and migrants often experience stigma around seeking help, similar to the general population in Estonia. At Vatec, we prioritize raising awareness and promote a more supportive environment for all individuals in need of mental health and psychosocial support.
Ultimately, it is important to explicitly include refugees and migrants in health policies. The idea is to have one common system for everyone. This makes sense, but it needs to be very clear that some groups need additional help with thriving in this common system.
Каждое новое начало всегда кажется очень трудным, особенно в нашей ситуации. Но как только вы поймете эстонскую систему, вы поймете, что это очень здорово. Я благодарна за помощь, которую оказали эстонские врачи мне и моему ребенку.
Improving these areas will result in strengthened capacity, greater inclusivity, and overall enhancement of the health system's effectiveness. Estonia can serve as an example of how the experience of an upsurge in arrivals, with the potential to put a significant strain on the health system, can be transformed into an opportunity for positive change for all. It highlights how growth can occur from unexpected circumstances. Together, we can turn knowledge into action and create a world where no one is left behind. Every person deserves access to healthcare, no matter where they come from or where they are.
An applause for the video team that prepared this important video from Estonia. Dr. Severoni, how important it is to surpass this challenge of cultural barriers? It makes the difference for migrants and refugees.
Cultural barriers are only one of the barriers in accessing the health system. Estonia just proved. This video is fantastic because Estonia is a country of high income and high level of capacity, recognized to be a champion in health system functioning for a number of years. Just to recall that the country has been producing the Tallinn Declaration, which has been the policy framework for health system work in the last 15 years in the European region. So we are talking about excellency. But the value of all this example is that even in context of high-level capacity, we recognize that we need to deal with a diverse type of population, and this might need tune-up of the health system. And the message at the end of the video, where the work on Ukrainian refugees has been helping to improve the capacity of the health system for the benefit of the whole population, is the same I heard from the Deputy Minister of Colombia 1 year ago. So this is the reason why I'm keeping saying that compassionate element is important in our work, but also we need to understand that we are dealing with a very technical, practical element of public health and strengthening health systems. And the experience of Estonia really it's inspiring our work, because they show us how responsiveness in improving the health system capacity by removing barriers, resulting in a better performance of the system.
Yeah, I have a curiosity. Is there a rule in terms of what is better, creating a new system and a specific system for migrants and refugees, or integrating them to the systems that are already working for locals?
I love this question because it's very much about the subject of today, related to evidence supporting the policy decision. We don't have a fixed rule, but we do know very well, based on a long time of practice, science, research, evidence, data, how public health is supposed to function. And just to mention the latest critical situation like COVID experience, COVID showed to us that generating pouch of population underserved actually leading without hesitation into failure of the health system. So the inclusion is, I repeat, is not an issue of charity, but is an issue of better performance of the health system. It's an issue of cost effectiveness. The removal of linguistic barrier that Estonia mentioned, and Estonian language is very difficult indeed, it's important because it's going to facilitate the access to preventive services, navigation to the system. In certain countries, this might be impacting also the out-of-pocket payment, if you know how to navigate the health system. So it's really, really the core of our efforts in promoting the health aspect related to population movement, migrants or refugees they are.
Well, the fact is it is very important that countries share information and cooperate among them, because that way they can prevent to go to the same mistakes than others that already detected and corrected, isn't it?
The sharing of information among countries is important, but we are having some open, undefined discussion about safety of data storage and utilization of the informations. This is very sensitive in nowadays. The debate on this subject is interesting in different sectors. What is important in terms of the experience of Estonia, they realized that the health information system is supposed to be centralized. We still unfortunately see parallel attempt of health system to serve migrant refugees. different government entities. So there, the message very powerful is that the country immediately understood that they need to protect the unity of the health system. This is our work, is our appeal, is our advocacy. The health system need to be one and need to be able to be effective, need to rely also on a strong health information system. So data need to be available, evidence need to be available.
Thank you, Dr. Santino. Now let's go to our keynote speaker for today. He's gonna be live from Geneva. He's Dr. Jeremy Farrar, WHO's chief scientist. And hello, Dr. Farrar, we can see you, hello. How are you? He's gonna talk about the role of research in impactful health policies. Dr. Farrar, welcome and please go ahead.
Thanks very much, and I can only apologise for not being able to join you in person, but it was a pleasure just to listen to that, to watch the video just that showed, which was really inspiring, I have to say, and it's always good to hear from my very good friend and colleague Santino there, and just to say that I agree with everything he just said, and we didn't compare notes before he was talking, so I think his words are very, very, very wise. And it is a pleasure to join. In fact, originally, when Santino asked me to join this, I did a video recording, but because I think this topic is just so crucially important, frankly, to the sort of world we want, that I asked if I could join in person. So it really is an honor and a pleasure to join, and thank you very much for the invitation. So I'm Jeremy Farrar. I'm the chief scientist at the World Health Organization. My background is, I worked for 20 years or so, 18 years in Vietnam, between 1995 and 2013, and then for the last decade was head of an organization called the Wellcome Trust based in London, and then moved to be the chief scientist at the World Health Organization in May of 2023. And it's been both an honor and a pleasure to hold this position, and especially to work with some great colleagues who are in the room with you, including Santino. So thank you very, very much. I'm going to start with a sort of pessimistic scenario of the world I think we're in at the moment. But I hope during the course of a few minutes to end on an optimistic note, because I think sometimes, and I'm sure many of you in the audience, online and in person, almost have stopped looking at the news because it is so at times distressing and difficult. And my plea would be to not turn away from it. Because the world often goes through and has often gone through in history difficult times, and we're going through an extraordinary difficult time at the moment. But if we're going to come out of that, and we are going to move into a better place, it will only happen if we're active and if we inspire, if we push, and we think and talk, and through evidence and science build a better world. If we do nothing, then things will get worse, and that is not an option. And there's few more, I think, important issues to address as a world than the topic of the global school that you are part of in this discussion. And perhaps finish this opening remarks by saying, I think we should all be judged by what we do for the most vulnerable in all of our societies. And people who are displaced, refugees, migrants, people that are forced out of their home and their places, not just through charity and support, but it says something about the sort of societies we want to live in how we address those issues. So there couldn't be a more important topic, and that's why it's such an honor to be able to join you, and why I insisted to Santino that I joined at least in person rather than through a video message. So we do live, and in my professional life, I think I've not known another period of such uncertainty. And you can discuss and debate what the uncertainty is, but it's of course about conflict, it's about intergenerational issues, it's about inflation, it's about the economic environment, it's about job opportunities for young people, it's about people that are being forced out of their homes and their lived environments into new environments which are frightening, fearful, and dangerous. And as you know better than I do, there's probably almost close to 1 billion people who for some reason or other are forced to live in a different part to where they would choose to live. And that is likely to be a feature of the 21st century through climate change, environment change, biodiversity loss, rural-urban divides, and other pandemics, and many other features of our current world. It is likely that this issue is not just suddenly going to go away. And so I think we have to take a sustained, long-term approach to this rather than thinking this is just going to be solved with quick fixes. We do need urgent action, but in the same time as we're taking urgent action, we need to think how we can sustain this through the evidence, through the science, through the research, through community engagement and involvement, and critically through the way that we articulate and communicate within our societies and to our political masters and people in positions of authority and power and capable of making decisions that can turn that evidence into action, which was one of the phrases used in that video. At the same time as that degree of uncertainty, which we all feel in our individual lives, let alone the most vulnerable in all of our societies, we are also in what I regard, again, in my professional life, a scientific golden age. If you just think back over the last 1 year, 5 years, 10 years, 15 years, in your careers, what has changed in terms of technology, in terms of science, in terms of our understanding, in terms of innovation, whether that be in biomedicine, in public health, in social sciences, behavioral sciences, then I don't think I've lived through a more exciting, dynamic, fast-moving scientific era than we are in at the moment. And it is absolutely extraordinary. And of course, some of that came through during COVID with the development in record time of vaccines for COVID, but it's actually happening across the whole innovation technology. If you think of beyond medicine and beyond public health, I think we are in a true scientific golden age. And I think our biggest challenge will be to ensure that we use that science not for the few, but we use that science for the many. And I do have a concern that increasingly science could, if we do nothing, drive increasing inequity at a global level and within our own countries and between our countries. If we do nothing, I worry that science will increasingly go on in a smaller number of places, will address issues of those with resources and money, and leave behind those that do not have a voice at the table as the science and the evidence is discussed. If we do nothing, that will be the outcome, I believe. And yet it is in our power, we have to believe that, it is in our power to make sure that science drives increasing equity rather than driving increasing inequity. And we can do that through many ways. And the discussion of this school and this meeting is about how we can make sure, in the final words, I think, from Santino there, and in the video, that science leaves nobody behind. Because science has a role to play. It has a role to play in all of our culture. It has a role to play in how we address the great challenges of the 21st century, from climate change to biodiversity loss, to inequality, to economic growth, to job opportunities for young people, to pandemics, to antimicrobial resistance, to the rise of non-communicable diseases, and to the challenge of mental health. Science has a role to play in all of those. And what we must make sure is this scientific golden age leaves nobody behind. I think we can do that, but we will only do that if we're active about it and we ensure that in meetings like this, we make the case that we want science to be part of a public good and that we want science to work for everybody. In terms of the issue of people that are displaced and the number of people that around the world are now living in environments that is maybe not of their choosing or of their choosing, we also need to appreciate that the time spent in those environments is getting longer and is almost becoming a permanent feature. And in doing so, I think we will address the issues of inequity and the services that need to be provided in a better way than if we assume that these issues are short-term. And I particularly liked in the video the idea, and again, Santino, sorry, in the WHO building, the lights go off after a few minutes if you're not active, so I just had to turn the lights back on. Apologies. The crucial point that was made in the video, and Santino reiterated, and I'd just like to make the point again, that we also should not see this just as charity and vulnerability, but we also must see, and I believe make the case in all of our societies, that this is about not other people, but this is about all of us. This is about improving access to healthcare, to improve access to services that will be benefit to everybody in the room as well as everybody else. And if we make the case of this mutual benefit, rather than this is about helping other people somehow in the distance, then I think we won't sustain the public support and the political support for it. So the case in the Estonia and the case that was made very powerfully, that actually this is about improving overarching healthcare and healthcare delivery and access and services that improves everybody's lives, as well as those most vulnerable, is, I think, an absolutely crucial argument to make. If we do not make that argument, my concern is that this will be seen as something that is done in an almost charitable, philanthropic way for people and with people elsewhere. I think we need to make the case that this is of benefit to everybody and it affects us all. And by improving those services, as Estonia has shown so in such an iconic way, I think is a way of ensuring that this remains part of our everyday lives, rather than something which we do for a short period of time and we move and then we move on, and it's about helping people elsewhere. I think mainstreaming this in embedding it in everyday life is the way we will be able to sustain it. The other part is that science doesn't exist in a vacuum. Science exists because the societies which it's part of support that science. And I think over the last 5 or 10 years, with the rise of populism around the world, science has been seen as something conducted by an elite somewhere in ivory towers, divorced from the reality of people's lives. And increasingly, I think we need to break that down and get out of those ivory towers, get out of that sense of elitism, and embed within science, from its inception and from its original thinking, the lived experience of people with the experience that really matters, rather than dreamed up in places where that lived experience does not exist. By ensuring that the lived experience across the whole breadth of science is embedded in its initiation, its thinking, its development, and the way it's framed, means, I believe, that it'll be grounded in reality rather than in some sort of ideal ivory tower sense of where science can and cannot play a role. And so embedding lived experience and people who are grounded and who have knowledge from personal experience of the way services can be delivered, I think is something that we need to bring into the scientific community in a much stronger way. The other bridge that I believe we have not succeeded in ensuring is making sure that science, that evidence and its grounding in reality is available in accessible ways to the political and policy arena that is so crucial if we're going to make change at a national, regional and global level. And a concern of mine at the moment is that science is increasingly diverging from the political, policy and diplomatic communities, and we need to make sure that they come back together. so that we can anticipate what science is coming. We can embed science in policy decision making so that policies are made with the best available evidence that we have, and that we can ensure that science, evidence, and research informs that policy, that then people making political decisions can at least have the best available scientific and research evidence, including in the aspects of movement of people, migration, refugees, and people displaced from their homes. This has a policy arena, and we must make sure that the scientific evidence is available to that. And this is one of the pieces of work, including with Santino, that we're working on at the World Health Organization, to ask how countries structure and organize their scientific advice into government, not in a crisis, but all of the time. Because I think that if we don't, the science and the political and policy arena will increasingly diverge, and we will end up where policy and political decisions are made in the absence of scientific evidence, and I don't believe that will lead to better policy decisions. So one of the big areas of work that we at the WHO are working on in 2025 is how scientific research and evidence is both grounded by the reality of people with lived experience, but is also available to the policy and political decision makers in ways that are accessible to them, so that policy making can be made with the best available evidence and support that goes with it. And then the final thing I'd say is that everybody in this room, in different ways, virtually and in person in the room, although sometimes we may not think it, has power and agency. We are in privileged positions. We hold positions with titles after their name, we work for organizations, and we have power and agency. And with that power and agency comes responsibility. And there are many meetings around the world, there are many conferences, there are many warm words said, and you never hear bad words said at these conferences. It's not warm words that change the world. It's warm words that are then, when we leave these meetings tomorrow, the next day, next week, next month, next year, it's what we do when we leave meetings that's really important, not the warm words that we say. And what I would implore all of us to do is, when we leave these meetings, remember the warm words that we said, and hold ourselves to account to hold ourselves to account in the 12 months that follow, that we won't just say the warm words, but those of us who are in the privileged position of having some degree of agency and some degree of power, turn those warm words into action. Because if we don't do that, who will? And I think coming along with the privilege of power and agency comes the responsibility to act. And I would implore everybody to keep to the warm words, remember what we all said at these meetings, and commit ourselves over the course of the next week, month, and year to deliver on the warm words that actually makes the world that we want for the future, rather than necessarily the world we have today. And with those closing, and I hope optimistic comments, because I think we can make a better world, then I'll hand back to the chair and the organizers. And again, just thank hugely to the privilege of being able to join you in person. Thank you.
Wow. Applauses for Dr. Farrar. I want to say thank you, Dr. Farrar, for using this time not only to share facts, but to inspire us so much. And I love this sentence you mentioned earlier, which is sciences should be to increase equality instead of inequality. I think it's very important too. Dr. Farrar, I have a question for you. Can you stay a little bit more during our Q&A session? We have 2,800 people connected, so I know they would love us.
Or to reconnect.
Am I invited?
What did you say, sorry?
Am I invited to stay?
Yes. Yes.
Yeah. Oh, okay. Great. Great. Sure. Thank you. Thank you very much.
We are privileged to have him.
Yes, we have the privilege to have Dr. Farrar for our Q&A session. And let me share another important number. We have had 6,000 visualizations of a little bit more of our videos until today. So the third first days of the school. So thank you. Well, Dr. Santino, what do you want to add on Dr. Farrar's
I
comment?
subscribe. I love what Jeremy mentioned, but I like very much the sentence with which he concluded his intervention. Let's use what we are discussing in the conference, the good ideas, the good purposes, and the school meaning is this one, really to offer food for thought, but also for action later on at home, because the idea is to try to generate a critical mass of colleagues, people, friends that better understand the challenge of this area of work, and they going to work in their own sector, in their own specific context to improve the system. The other point that I really like from Jeremy, the call for science to move out from the ivory tower. This is very important for us because my team, my colleagues, analyzing the health investment into research on health and migration, discover very interesting facts that nowadays 97% of the resources going for research on health and migration are going to academic institutions in high-income countries. This is fine, it's not a sin, but of course make us to think that the research ongoing on this topic is a bit of in vitro probably, and we should probably do also something more to bridge with academic institutions where actions actually happened. I've been repeating here in Colombia every day how important it is to document the experience of Colombians in including 1.5 million of migrants into the health system. So very, very important to bridge the global north with global south in terms of research.
Thank you, Dr. Severoni. We are ready for our Q&A session, so Professor Cabieses is coming. And while she gets the stage, I want to remark that it amazed me how you have been able to do research while attending humanitarian crisis. It shouldn't be an easy thing to do, and you have managed to do it, so it is important for the world. Professor Cabieses, welcome again. How are you?
Thank you. I'm very well, thank you, Claudia.
Good. Allowed me to start by suggesting that you share your own thoughts on this, because you are a researcher too.
I am, yes.
So how do you manage the challenge of researching in something that is useful for public policy design?
Oh, thank you so much for the question. I will be giving questions to other people today, but I will take on your question, and I think it's a very complex and challenging balance to do research, if you love to do research, but then taking the time and effort and money to transfer it to something useful for the audiences that you're working with. And I say not that you're researching on, but working with, as a sense of that we are working with people who also have their own knowledge, system of beliefs, way of seeing the world that deserves attention, valorization, and has to be brought into research. So I think the way we do research, the way we ask our questions, and the way we transfer is at the heart of what we should be doing every day.
Sure, thank you.
Pleasure.
Please go ahead with the round table discussion.
I'm so happy to be once again with all of you here in the room and online for the Q&A session today. It's our 4th day. It has been a fantastic day. We have had fantastic, inspiring video reportage first, and then keynote speech from Dr. Farrar, and I want to thank them both for the effort that they are doing staying with us. So today, as you already know, we're talking about research in relation to the health of migrants and refugees. And that is a global challenge that has important gaps that we need to address. I would like to thank our global audience who have been connecting with us during the past 4 days, including this one, and who are also commenting, sharing thoughts, experiences, ideas, reflections, questions to us every day. Thank you so much for staying connected with us. You make this matter and you make this relevant, and the effort made here today and the entire week here in Bogota, Colombia matter. Thank you so much. So I will start by introducing today's panelists who are available to address questions today. Of course, our host, Dr. Santino Severoni, we have a few questions for you as well. Our keynote speaker, Dr. Jeremy Farrar, what a fantastic keynote speech. Thank you so much for that. And I will be addressing a few questions for you. WHO's chief scientist expert. From the host country of Colombia, I invite to come to the stage Dr. Franklin Prieto. Dr. Franklin, thank you for being with us today. Please come over here and sit next to us so that I can address some questions to you as well. He's the Technical Director of Public Health Risk Surveillance and Analysis at the National Institute of Health of Colombia. We also have from WHO, Dr. Miriam Orcutt. She's a Technical Officer for Research at WHO Health and Migration Department. Thank you, Miriam, for being with us today. It's fantastic to have you on this panel discussion. And finally, in relation to the video reportage from Estonia, we have Christina Kohler, Liaison Officer at WHO Estonia. Christina, thank you so much for being with us today as well. I will begin. The first question addressed to Jeremy Farrar. It's coming from Valentina from Italy. And the question is the following, Dr. Farrar. Given the pressing need to address health challenges linked to migration in low and middle income countries, what strategic approaches can WHO and its partners adopt to strengthen sustainable funding and build local research capacity in these regions? Dr. Farrar, the screen is yours.
Well, thanks very much for that question. How to start? The first thing I'd say, much of my professional career spent working on epidemic diseases, and if you went back 20 years, there were questions about whether it was ethical to do research in the context of epidemics and indeed pandemics. I made the case 20 years ago that it was actually unethical to not do research in that context, and I think that has become the norm. And I think the same applies in this arena as well. There are hugely important questions to answer if we're going to have better policy making, and with the consent and agreement and engagement and involvement of people who are living in displaced populations, I think research is an absolutely critical element of that if we're going to have better policy decisions and not have movement back to populism, etc. So just to make a plea for the research in the context of humanitarian crises. On the issue of research and science and where it is conducted, and I hope from my own background of 20 years conducting research and being a clinician in Vietnam demonstrates that I think there has to be a shift in the center of gravity of where science and research is done. And in 2025, and I'd be delighted to share some more on this if people in the audience were interested, we will be leading from WHO a commission on looking at how countries use their domestic resources to support their scientific ecosystems. Because I think domestic resources are what really matter, whether it's $1 or $1 billion. And how you use that to support research and science within a country and then within a region is critical. And if we are going to address the historic legacies of colonialism, and if we are going to address inequality and the power imbalances that exist between the so-called North and South, then I believe that the scientific and research center of gravity has to shift. And for countries to invest in their own scientific domestic ecosystems and then leverage international partnerships. And so this is a piece of work that we will be launching in 2025. And I sincerely hope that many partners, including in the room and online, will be interested in joining that, in ensuring that science is done where the science is needed and with the engagement of the people with the lived experience of what is needed in the countries where the questions are raised. So I think that shift in the center of gravity is essential if we're going to address the challenges of the 21st century.
Thank you so much. We look forward to learn about that launching of that document and information. Thank you so much for that. I have a question now for Christina Kohler. It's coming from Olanture Oyinde from Nigeria. And the question is this: what are the best practices that you can share and that could be applicable in other hosting countries in terms of transferring research into policy in relation to health of migrants and refugees?
Thank you for the question. And just to come back what has been said among the other panelists is First of all, I myself am a strong believer of evidence-informed policymaking. And I think that data and evidence is useless when it's not used, meaning it should not be collected when it's not used in order to change the lives of people, and especially when we talk about health. But coming back to this question, thank you for the question. And perhaps I will focus in my answer on data and evidence use, how it has been done in Estonia. And perhaps the first thing to mention is the health system assessment that was done. This is also creating evidence and data to make informed decisions. So this helped us to get the overall picture and understanding of what are the challenges and gaps in the Estonian health system when it comes to refugees and migrants. But coming back to when it all started, let's say 2022, when the influx of refugees was much, much higher than ever before in Estonia, then what data was used was that Estonia and Ukraine shared data between each other, and based on that data, looking what are the main health issues, initial health check was developed. So these tests and things were checked where we know that they make sense, looking those health issues among Ukrainians arriving to Estonia. Then also the data that is collected among people, let's say general, in Estonia is collected and sent to the central e-health system. And this also means that we can project the costs of the data and we can use the data. And this data is also shown to everyone who is interested to seeing that in the Estonian Health Insurance Fund webpage. But this is also used for planning the services and service development in the country. And of course, what has been done as well is conducting qualitative and quantitative research and studies among Ukrainians living in Estonia. One of the examples is vaccination study that was conducted in Estonia, in addition to among Ukrainians, also among Estonians, to see what are the differences and barriers between those population groups. And also this year, a health behavior study was conducted among Ukrainians. This is a study that is conducted among Estonians every year in Estonia, but now also we know the differences between Estonians and Ukrainians living in Estonia. And what else has been done is that when Ukrainians arrived, first, some of them lived in accommodation centers. So there were no camps in Estonia, but accommodation centers. And in those accommodation centers, the information about the Estonian healthcare system, how to access the system, how it's different from Ukrainian healthcare system was provided, meaning that it was conveniently provided to Ukrainians. And also what was used was the religious leaders, because not everyone lived in accommodation center. A lot of the people actually, even now, are living in communities more than in any accommodation centers. So we went where the people are, basically. And the other thing is that initially when temporary protection is received, there is also induction course by the Ministry of Culture provided to refugees that explains how the system works and how to access healthcare system in Estonia. And some of the health promotion campaigns and materials were also done in Ukrainian language, of course. But of course, there are still challenges in the system, even though it's a high-income country, but there are still challenges. We do have one health mediator that is needed in order to provide the services, but we have only one health mediator, and it started this October. So there are still more needed to be done. And of course, health promotion campaigns could be better targeted, meaning that they should be developed, including and tested with Ukrainian refugees, whether they actually address them nicely and whether they are understandable, because the populations are a bit different. And what else are the challenges, I think, is of course lack of general practitioners and healthcare workers in general, and language barriers. And of course, the knowledge of Estonian healthcare system that came out of the health system assessment, we know that it's still not very well known among non-Estonians living in Estonia. So there is more work need to be done related to this. And I think what was also mentioned before, which is a barrier among Estonians and non-Estonians, is co-payments, because this can cause barriers in accessing healthcare services. And using this influx of refugees, there are discussions, using it as a window of opportunity, let's say, there are discussions about widening health insurance coverage in Estonia when we talk about primary healthcare to all of the population who are in Estonia. There are also 4% of Estonian population who don't have health insurance coverage. So this initiated this kind of discussions to improve the access to all of the people who are living in Estonia.
Wonderful.
And in addition to that, also the co-payments should be lowered, and this has been something that has been discussed. Yeah, sorry, thank you.
That's excellent. Thank you so much for sharing with us some examples, concrete examples of things that can be done for transferring research into policy and practice based on the experience of Estonia. Thank you so much for that. I will move on now to Franklin Prieto, who is in the room with us. Thank you so much, Dr. Prieto, for being here with us. There is a question from Asma from India, which is, how does information contribute to timely decision-making in a migration context in Colombia? In other words, how scientific evidence should inspire correct communication and information. Please, the screen is all yours.
Thank you. Well, I am going to speak in Spanish, okay? Creo que hay una...
There's a series of elements of what has meant to convert the information so that public policy is useful. And it goes through a first element that belongs to public health, and that is to identify the usage of elements that require an analysis or special interest with this name. That is to say, we easily use the denomination disease or event of interest in public health. Our first reflection from the National Institute of Health is to think that we should also speak about populations of interest in public health. And what this means is that we do not actually analyze the events that come to that population and their diseases in isolation for experts, but we attempt to consolidate the information so that once it's centralized, we can have an ideal response to the information that is going to be produced. Secondly, is to understand how to incorporate this in something that is so essential, such as vigilance in public health. In fact, this is one of the essential functions. And in that scenario, it led us to also recognize the flow of Venezuelan migration in 2016 and 2017, understanding that we had to recover information in 4 environments. The first environment, which is that which is surging, which has in conditions of greater vulnerability, and it could happen with diseases of our territories that do not necessarily exist in other territories, events that are of international concern and that require to strengthen vigilance in a scenario of greater vulnerability. The demand of services that could mean the fact that a country that has lost its structures of service in health can offer it and tend to migrants, to refugees looking attention in another city. And lastly, that situation that had been tended to in other countries, and due to the vulnerability of the structures of these countries, the need of being able to incorporate them in the vigilance processes. The third element then would be that with this information, how could we motivate our reply, our response? And the motivation of the reply or the response is by integrating all the risk management situations. If we want to change situations, we have to have a structured form to react before the identification of situations, before the identification of both the population that I mentioned and also of the diseases that are affecting the population. And also somewhat with the experience of Venezuelan migration led to a fourth element, which is essential in the environment of this policy, and that is that the data might not be turned into a tool to generate stigma and discrimination. During 2018 and 2019, the country lived an important epidemic of measles due to the migration of Venezuela. It would have been very easy just to inform, but not just inform, but he also informed under protection. What could this mean to inform under protection? At the end of the day, we were able to have made that if a citizen migrates through a country that has a epidemiological risk, in this case measles, would not be translated into citizens be pursued just because they come from that country and that they bring a pest or epidemic. So this has led to be mature. Something that is so simple as just capturing the migrants' information. We, through the vigilance system, we've had certain versatility so that information of people that come from abroad, of people that are now resident, is easier to capture within the system. We cannot get to the environment or waiting for a doctor that at the end of the day is the one that reports the situation of an interest element to fill out formats where we ask a lot of extension in the topic of the migratory situation of the people. But yes, with certain tools of versatility to be able to capture this information and to have information up to date, protected for decision making. So undoubtedly, we have to incorporate all these elements in something that is as practice as vigilance, and this could contribute to actually have situations change, both for those that receive.
Integrated research for integrated care. Fantastic point on that. Thank you so much. I would like to everyone know that Dr. Farrar had to leave because he was committed to a different task now, but he was, of course, wonderful to have, and we wanted to know here in the room and those connected online that he had to leave. So we will continue our Q&A with all those panelists that are still connected with us. Thank you so much, Dr. Farrar, for being with us today. I will move on now to our other panelist, Dr. Miriam Orkut from WHO. Dear Miriam, thank you again for being with us. After this question, I will ask all panelists to start giving brief answers, please, no more than 1 or 2 minutes responses, so that we can cover as many questions as we can from our audience. So, dear Miriam, a question for you. What are WHO's key actions and recommendations for addressing the gap between policy, practice, and research, and strengthening evidence-based policies on health and migration? The screen is yours.
Thank you so much, Baltika, and thank you all for the interventions so far. So, of course, you know, this very much builds on our work over the last years on the global research agenda on health, migration, and displacement. But really what that brought forward were a few key points about how do we bridge the gap between policy, practice, and academia to address these key research and evidence gaps for policy making that are really essential for us to achieve the SDGs. If we don't invest in research and evidence on these areas around health, migration, and displacement, really there's an urgent need to do this in order to achieve the broader global public health goals. Now, what we have seen is that actually in our implementation of the global research agenda, we've been working at the regional levels with regional offices within WHO and also within countries with ministries of health to further develop contextualized research priorities on migration, displacement, and health. And also we've been working to further address the gaps at the global level that were brought in the global research agenda through things like our global evidence reviews on health and migration. And really a few key things have come forward. One is we need to continue the dialogue and collaboration through the whole process of evidence generation, knowledge generation, and research, where we have policy and practice with us from the start, from the inception of the research question and the evidence gap. What is needed within the policy sphere? What are the evidence gaps needed? But we also maintain that dialogue, that collaboration through the whole process, so that as we have the generation of evidence, we also have the integration of policy and practice stakeholders. And as we come to the findings, these are actually translated already with those who've been collaborating with us through the process. Now, one thing also that we really have seen coming forward through our collaborations with different actors within ministries of health and at the policy level and within practice is what is evidence? What do we consider to be evidence or even research? And actually, one of the things within the space of health and migration is very much that a lot of the evidence is held within policy, experiences, lessons learned, but also within practice, people who are working on the ground. It comes back to the point also of including those communities and individuals who are actually those who are affected by issues to do with migration and displacement. And actually these 2 points about inclusion, dialogue, and also considering that evidence needs to be all-inclusive, that we need to have a broader perspective, so that when we are having our processes, which are very important around research agenda setting or around research and evidence collation, that we ensure that the ultimate output is also something that can be used and implemented rather than just something for a publication. And I think the final last thing, just to note, is around when we have evidence that is existing, why is it sometimes not translated into policy and practice? Because we know very well there's a huge amount of work in this area. There's a huge amount of actors who are producing evidence on this topic. And sometimes there we come back to what was brought forward by some of the 180 stakeholders who were involved in the global research agenda in our call to action at the end of the process, was around the fact that we need to strengthen equitable and inclusive research collaboration, but we also need to strengthen sustainable funding mechanisms, so that we know that the funding is going to those regions where they're experiencing most migration and displacement. And ultimately, at the end of the day, also to work so closely with our policy colleagues and with ministries of health in our member states from WHO perspective, to actually have those dialogues, as well as have that ongoing political will around translation of this into the policies and legislation. So I think those would be the 3 main points I would raise. Thank you.
Thank you so much, Miriam. I think you have raised really crucial key points that need to be addressed in terms of producing research on one hand, but also in translating it into policy and practice. Thank you. We have finished our first round of questions for our panelists. Please, all of them, stay with me, stay connected, stay with us, because now I will give the room for the people in the audience to ask for 1 or 2 questions. So please raise your hand right now if you would like to ask a question to our panelists, and we will get a mic for you right away. Is there any question? Thank you so much. Fantastic. There is a person coming with a mic. Please share with us your name, your country, your question, and to whom it is addressed. Thank you.
Hola, buenos días. Mi nombre es David Foronda, coordinador de salud mental, apoyo psicosocial en Medical Teams Colombia.
Mental health coordinator in
Mi pregunta va dirigida, ¿qué
The
recomendaciones?
question is directed to recommendations and good practices that could be mentioned to provide greater participation to decision makers, community diagnosis, and unification of projects in environments of mobilization.
Maybe Dr. Prieto. Dr. Prieto, would you like to take on that question?
Doctor Prieto, ¿le gustaría responder esas preguntas? There's a scenario that the country is developing quickly. First is to generate primary care, is one historical debt in the country. And the second point is to develop vigilance processes based on community. We understand that it was part of the historical debt that the country has held in all fronts. It's to be able to influence within public policy in a true scenario of approaching, first of all, that is to say that the Institute will need to have the capacity to approach the community and for the community truly be an agent of change. So undoubtedly, the change that we've done in this government has one of these goals for the community to participate in development. Undoubtedly, the scenario of primary care that is not just proposed, at least from the topic of health, the basic equipment of attention, but also the recovery of some community agents. That's the first of the vigilance based on community. The second is healthcare promoters and the social organization in itself. We are entirely convinced that to be able to modify the conditions of the population, the conditions of whatever it may be, obviously, we're speaking about health, it's necessary for the population to be a participant in that field. If the population does not participate, participants were going to do activities that will not really be a solution.
Question. Is there any other question in the room? If not, I will give a new opportunity in a few minutes. I will move on to Christina. Dear Christina, a question from Sajjad Ali from Pakistan addressed to you. From the experience of your country, how can research influence capacity building for health workforce? The screen is yours.
Thank you very much for the question. The health system assessment that was conducted in Estonia, we did find out that there is a need to empower and to look over the competency standards of the healthcare workers in Estonia. And as a first step, last week, WHO trained policymakers to enhance the health outcomes for refugees and migrants. And Estonia was the lucky one to be among one of the member states who participated this course. And this training is guided by the evidence based on global competency standards for health workers. And this course gave an overview what are the competencies and behaviors that are needed to provide culturally sensitive and inclusive healthcare to refugees and migrants. And from Estonian side, the University of Tartu and Ministry of Social Affairs and the country office, WHO's country office, participated there. And as a next step, we will look over the curricula for the general practitioners in Estonia to enhance and fine-tune the curricula with the needed competencies to reinforce healthcare workers. But I think coming back to perhaps the question like mental health services in general, and what has been done as well in Estonian case, I guess I think it was rightly emphasized that community level is something that we need, and Estonia did ramp up community level mental health and psychosocial support services, because this is where the people live in reality. And also we did a lot of multi-sectoral MHPSS coordination and activities, meaning that we did not provide capacity building only for healthcare workers, but also for social insurance board, police, local governments, religious leaders. Meaning that when we do want to reach the people, because there might be among refugees and migrants and also local population, stigma around mental health and getting the services. So this integrating multi-sectoral approaches and capacity building is really much needed.
Fantastic, thank you so much. Do we have a second question from the room? Anybody? No? We move on. I have a question for you, dear Miriam. It's coming from Tatiana Ramirez from Germany. And the question is the following. Could you please elaborate on the WHO's global research agenda on health, migration and displacement? What are the outcomes and how is now being implemented in practice?
Thank you so much. And so the outcomes, we had a process with equal representation from policy, practice and academia across all regions, over 180 stakeholders. And of course, we have 5 prioritized key urgent themes of research to address at the global level. They relate to really areas that are relevant to all of global public health. So from addressing inclusion of refugees and migrants and displaced populations within universal health coverage and health financing mechanisms, to addressing how do we address the social determinants of health most effectively, and inclusion, how do we include best within preparedness and response to health emergencies, through to more cross-cutting themes. So the last 2 core themes were around building evidence on under-researched groups and then strengthening equitable, inclusive research collaboration. So those were the findings. Now, how do those findings and that publication of the global research agenda translate into implementation? Well, we had an implementation guide, and of course, many global actors are taking forward parts of that, including aspects of the global call to action. But from WHO side, we also have a few key areas where we are also moving to address those global evidence gaps and inequities. One of those key areas I mentioned briefly, so we're translating it, working with regional offices to make regional research agendas relevant to their context on health, migration and displacement. And then also at the national level, having national research agendas and research action plans with ministries of health and stakeholders within those countries. Now, the process of this research agenda setting is also important because, again, bringing together actors between policy, practice, and academia to discuss what is the evidence base, what are the gaps, but more importantly, what do they need in terms of evidence for policy and practice is very key to not only having a research agenda and research priorities, but actually to the next stage, which is how do we address those? And then how do we translate those evidence that we actually produce into action at the end of the day? The other two areas that are the outcomes really from our perspective of WHO, of implementing the research agenda, are that we are also working around further strengthening of the evidence gaps. So this is in a few different ways, one of which is looking at particular topic deep dives that came up as priorities. Some of them are around topics such as health, migration, displacement in the context of climate change or under-vaccinated populations. And the third thing is around continuing to facilitate what has been raised quite a few times today and other days in the Global School, this dialogue and formation of dialogues and research and evidence transfer of knowledge between policy and practice and academia. And we're doing this in two ways. One of this is by the formation of the Global Research and Evidence Network next year on health, migration and displacement, where we will continue to have platforms to enable that dialogue. And then the second thing is around a global engagement webinar series. Now, of course, one thing that we can say is how do we measure actually these outcomes and this impact? And the last thing I would just like to end by saying is that ultimately we also have a monitoring and evaluation plan for the Global Research Agenda, which involves not only looking at how the themes, the 5 core areas, have been addressed and have changed the global landscape of research, how are they being addressed by broader actors within academia, within other UN agencies, within policy and practice, how are these being translated at a country level into practice, but also looking at the funding landscape. And this is something that Santino had alluded to, where we have done a baseline funding analysis, global funding analysis. Where is the global funding going? And what we are looking over time is to see how the funding is actually being allocated more, hopefully in a more equitable fashion, towards those who are experiencing highest levels of migration and displacement, but also to the topics which relate to the Global Research Agenda. So really for us, it's a continual process. It's about evidence for policy action. It's about continuing that dialogue and making sure that we can be facilitators and leaders also within that process of strengthening evidence and dialogue between policy and practice and academia.
Thank you so much, Miriam. We are, as always happens, starting to run out of time, so we'll kindly ask our wonderful panelists to be as brief and concise as you can. Santino, I have a question for you. It's coming from Moses Asa, MSF Nigeria. And he's saying, thank you for the chance to learn from your experiences. I work in the field with MSF in Nigeria. We agree that good research is important for many reasons, especially informing policy and evaluating the efficiency of current service delivery models. I would like to know what your organization is doing to help further research among migrants and refugees in sub-Saharan Africa. I think we have a lot of work here and also possess the potential to perform way better than we currently do. Dr. Severoni.
Thank you, Baltica. Well, Musa has a very important point. African continent play is important role in managing migration. Despite what is the narrative and the rhetoric about migration, Africa is hosting, or better, the refugees and displaced population in Africa tend to remain in Africa. 84% of the population of migrants, refugees, stays in the continent. So what we see out of the continent is small perception. In the continent, there are a number of very interesting initiatives in strengthening health system coverage for the population, including migrants and refugees. We alluded several times to Uganda, Kenya, and other experiences. Basically, the answer to Musa's question partially was provided by Miriam. So now, with the research agenda, we are really engaging into mobilizing commitment to roll out the implementation. What do we mean with that? We mean to establish a dialogue with the country, maybe to start by conducting health system review, so to see the place of weakness and strength of the health system at country level, and then support the country by replicating at national level a research agenda to run evidence gathering at country level and to use this evidence for policy formulation. In many cases, this is happened through a fragmented vision of what is reality, or there is difficulty to address answers to public health challenges or policy challenges because evidence is lacking in these countries. Africa is a priority continent. I'd like to conclude by saying Africa is a priority continent. There are already a number of academic institutions with whom we have established a collaboration, a relationship, and a dialogue. I think there is a lot of excitement from the academic institution in Africa to engage, to come forward, and to collaborate with us. So personally, I found extremely stimulating environment and possibility of showing good results.
Fantastic. Good opportunities, great interest in the region. Thank you so much. Now we have a question from a person in the room, Gabriel Farrar from Canada. So we are handing a mic to him right now. Please share with us your question and to whom it is addressed. Thank you.
Thank you. Gabriel Farrar from the University of Calgary in Canada. La pregunta para el profesor, so I'll try to do it in Spanish, si puedo.
The question is on the I am very interested in the evidence that is lent for vigilance and surveillance. One of the issues that we find in research is that it's very slow because in Canada, as coordinator, one of the issues that I see in countries at high level of economy, such as Canada, US, and Switzerland, are each province in each canton in their own healthcare system, they do not communicate one with the other. We could not have vigilance to all of them. Secondly, the second issue is that in our area of investigation with migrants, as you were saying in policy, province of migrants, refugees, there are no great data sets for research because that information is not found in clinics and hospitals because there's great issues of discrimination and racism. So I'm ever interested in knowing whether you have practices. How can you skip these two barriers? How can you overcome these two barriers of vigilance? How do you obtain data in Colombia? And the second part is in respect to the privacy. Thank you. So in the first element, I believe that all countries have to think about strong information systems and to count on information systems in real time. Part of what has been the exercise of Colombia is that it has matured a system during 17 years, something that the countries have not done because they depend very much on governments. We believe that the initiative of Colombia of integrating all its diseases under vigilance in the same system is a practice, a good practice that all countries should perform. The part that happens is not just the fact that each province or each state is going to have its own information system, but that in addition to this, each disease has its own information system. We do not have that. We have a single system. All the territories have a single system. So in reasoning, this led us to be able to also to respond because it was a concern for the second point. And the second point is that before we live a situation of migrate and external migration, we had a very serious internal migration, and this led us to build the possibility of treating the migratory phenomenon within the country because we had forced displacements. We still have it. And on the other side, when the migratory phenomenon of Venezuela arrived, we began to see versatile forms that would not force the doctor to find out whether he was a refugee or what type of migration the person had, the person that they were treating. Because, for example, if we do the same valuation of the ethnical belonging or ethnical condition, then the doctor is not going to do an exhaustive exercise to understand, well, the other person is acknowledged in the same way. The same thing happens with migratory processes. So we believe that part of our epidemiological intelligence is based on attempting to have the information in the simplest way, can give us a guidance in this topic. As I mentioned previously, we need to have this information. One of the great challenges is with cybersecurity. But aside from cybersecurity, I believe that we have to again speak about the ethical appropriation of data. And it's something that you've said, and I agree with. We have to bring public health closer to academia because academia is slow and public health needs to be quick. We cannot wait for an entire process of production of information from academia, but we know that there are very valuable experiences in their existence for intervention and not just for research.
We have one final question, just 1 minute left for you, Dr. Severoni. It's coming from the US, and it's how can we bring science into politics if politics is increasingly resistant to science? And the rise of populists across many countries in the EU and the USA. Thank you.
This is a really very, very complex issue. I think the main disalignment is the fact that politicians have a span life much shorter than the problem we are addressing. So the research and the policy offer solutions which are going to materialize across a window of time which doesn't match with the political timing. And that's the first element which is creating this alignment or lack of sometimes of politics in utilizing the evidence. But this is supposed to not be an argument for us to stop to produce evidence. We need to keep investing into that, also because this, let's say, turnover of politicians in reality allowed also to utilize what we are producing. The other element is that the work on research, evidence, solid facts, data is essential because probably few public health issues or social issues like migration, they suffer the level of political sensitiveness and polarization and misinformation about. So to walk the talk is essential. It's essential to invest into facts and keeping investing into facts in order to counteract the attempt of disinformation to drive maybe the information for the most into a political direction of benefits rather than the reality. I would say those two elements are the main difficulty in working together. Jeremy alluded that this is essential. We've seen in many public health matters that sometimes politics, for whatever convenient argument, they tend to derail from science and taking decisions unnecessarily science-based because politics need a certain approach.
Thank you so much. As a Chilean researcher myself, I fully testify how challenging this topic it is right now in every region and globally. I will finish now our Q&A session. I would like to thank our wonderful panelists, Dr. Severoni as every day, and the main host of this global school, Dr. Farrar, Dr. Prieto, thank you for being here, Dr. Orkut, and Dr. Kohler, thank you so much for staying online with us. And I would personally want to thank the WHO team leading this global school for trusting me with the Q&A sessions these 4 past days. Thank you so much, Dr. Severoni, thank you Candelaria Arauz, thank you Claudia Marotta, Chetin Dogan, Yoser Belorsru, and Giuseppe Annunziata. Thank you to the fantastic team behind this incredible global school. Back to you, Claudia.
Thank you, Professor Cabieses. I want to say what a nourishing roundtable discussion. Not only today, but today was really special because we have more time. Thank you for your professional way to conduct it. And you are saying kind of bye-bye because tomorrow you are not going to moderate the session. But thank you for your excellent job. Okay, Dr. Severoni, any remarks you want to add?
What a journey.
What, yeah,
what
a journey,
right?
Yes, very nice.
Really, really exciting. Very, very pleased to see a high level of interest. I think this is the most important, rewarding for our work, and also an injection of energy to continue to invest into health and migration work. Tomorrow we're going to have the concluding day. It's been flying the time.
Yeah.
At the beginning, it's looking always an endless effort, 1 week of daily sessions, but it's been really flying quickly. And tomorrow we're going to close with one of the most complex and outstanding issue of how we bridge emergency to non-emergency context. And in the area of health and migration, extremely important because we need to look at the long-term implication, impacts, and all days they prove that.
So we hope you come back tomorrow in this amount of participation. Today we have had the highest, I think, from the 4 days. So have a good rest of the day. Remember to fill the form. We are going to see the QR code in some seconds for you to scan it and could. What
I would like to add something in relation to the evaluations. It's
ahead.
not just a merely feedback, but really I would like to stress to the audience that for us are extremely, extremely valuable your feedbacks, particularly if there are negative feedbacks. Please explain what you would like to see better, because we are really using this to improve the next session. So it's really a benefit for everybody.
Yes.
Thank you very much.
We are open not only for applauses, but also for critics.
Absolutely.
Absolutely. Yes, thank you, Dr. Severoni. Dr. Elkin, thank you for being here too. Thank you for all of you who are here in the room, and for those who are attending online, thank you for being here, and see you tomorrow, same time. Bye-bye.